Our life's work is helping you protect yours. Copic's medical liability insurance delivers more than just a standard policy. Our physician-led leadership team supports and protects physicians, APPs, and medical facilities with expertise developed from decades of experience, CME-accredited education, and 24/7 hotline support from a physician. COPIC.com. We're Copic, here for the humans of healthcare, here for you.
As physicians, we're meant to be lifelong learners. This is a really exciting time in healthcare, and we should all, as physicians, shape how this technology is going to be deployed.
Welcome to Off the Chart, a business and medicine podcast featuring lively and informative conversations with healthcare experts, opinion leaders, and practicing physicians about the challenges facing doctors and medical practices. My name is Austin Littrell. I'm the Associate Editor of Medical Economics, and I'd like to thank you for joining us today. In today's episode, Medical Economics Senior Editor Richard Payerchin sat down with Dr. David Carmouche, an internal medicine physician and Executive Vice President and Chief Medical and Commercial Officer at Lumeris, a healthcare technology company, and a newly appointed member of the HHS Healthcare Advisory Committee. They're talking about the collision of two trends putting enormous pressure on primary care, a growing patient population with more chronic disease, and a shrinking physician workforce. Dr. Carmouche explains how he thinks about AI's role in that context, not as a replacement for physicians, but as a way to make the right thing the easy thing. And the conversation also covers value-based care's promise and its persistent execution problems, what AI-enabled continuous care could look like for patients outside the exam room, and what he'd tell a physician who's just dipping their toe in. Dr. Carmouche, thank you for joining us, and now let's get into the episode.
Thank you for joining us today.
Thanks, Richard. Thanks for having me.
And today we're going to discuss some issues around artificial intelligence, AI, and primary care. Before we get into that, can you introduce yourself briefly and discuss your education, training, and experience?
Sure, Richard. So I'm an internal medicine physician, as you mentioned. I did my training at the University of Alabama at Birmingham, was a chief resident, and was one of the rare chief residents from an academic medical center who chose to go into primary care after my training. I was in a multi-specialty group practice of about 110 physicians, independently owned, about half primary care, half specialty care for the first 15 years of my career. And really the last 15 years of my career have been in management positions across a variety of companies, starting with being the chief medical officer of Blue Cross Blue Shield of Louisiana, which is my home state, where I was hired after the Affordable Care Act was passed to help change the posture of the relationship between Blue Cross and providers to be from one that was kind of frankly adversarial to one that was more collaborative, and to pay for care outcomes that were important in a world where the insurance company was going to have to guarantee issue or cover pre-existing conditions. So really learned to like the business side and thinking at scale, and working in the boardroom and working across executive relationships to really create value was fun for me, and it led me down a career that took me to Ochsner in New Orleans as an executive running primary care and urgent care operations and our value-based care portfolio, our ACO, our clinically integrated network. And building payer relationships, payer partnerships, and employer partnerships as part of that. Did that for 7 years, and then had the good fortune to be able to take those 25 years of experiences and step out into a national scale and led Walmart Health for the last 3 years of its existence, trying to help Walmart see if it was possible for them to build community-based primary care practices inside of Walmart supercenters to kind of marry grocery and pharmacy and clinical services in an environment where people lived and where they were multiple times in a given week. Lots of learnings from that we could unpack, and then took all of that and came to Lumeris about 18 months ago. Lumeris is a company that for its history has been an operator partner for health systems and medical groups to help them manage risk contracts across multiple payers. And they were interested in this new wave of AI and generative AI specifically, and were curious if I would be interested in helping them think about how to responsibly and effectively harness the power of these technologies to help in their business. And so for the last 18 months, I've been on a technology journey, but really using a broad background of primary care activities across payer and health system and retailer to kind of inform my advice to the company.
To kind of start out with the technology, one of the technology questions, though, there have been all kinds of, studies, experiments, developments using AI in healthcare and other fields for that matter. In your own words, how would you describe the current state of AI and its best uses for primary care?
Yeah. I mean, I think to answer that, or to at least understand my answer to that, maybe 30 seconds of my perspective. And that is that we're kind of at a tipping point in this country where the needs for primary care are greater than they've ever been with the demographics of the aging population, the burden of chronic disease. There's never been a greater need for primary care. And it's at a time where the workforce for primary care is disappearing. If you think about it over the next decade, if there's going to be 85 to 90,000 too few primary care physicians, and the population needs more primary care, something has got to give. And historically, that the way we've solved for that is with team-based care, maybe adding non-traditional or non-physician roles to the care team, nurse practitioner, PA, care coordinator, social worker. All of those human resources are expensive and they don't scale very well. And today there's 100 million adult Americans that don't seem to have access to longitudinal primary care. So there's a problem that it's hard to see, the solution being a human capital solution only. So it's within that context that I think that the way that AI and technology should be supportive is to extend that human workforce, to allow them, to enable them to take care of more patients. Frankly, if you look at panel sizes of physicians in primary care over the last decade, they've shrunk. Largely, they've shrunk because we've added so many tasks to the primary care portfolio that they need time to do that. And so it comes at the expense of access. And so we need to change that so that humans could take care of more. And then the second is we just need to make it easier to do a really good job at being a primary care physician. That means removing administrative burden, but it also means removing cognitive load and things that consume energy of the provider that could be made easier with technology. And that's kind of how I see it. I think across all of my jobs, whenever, the thing that's always kind of stayed in mind as a design principle when it comes to physician invasive change, whether that's through technology or otherwise, is just make the easy thing, just make the right thing the easy thing. So make it easy to be a primary care physician and use technology in that way. So not to replace the really important human component to primary care, but leverage that technology to make that job actually easier than it is today. That's kind of how we're thinking about it.
In your introduction, you talked about your experience with some value-based care. And your company also works with technology in the shift from fee-for-service payment models to value-based models of healthcare. And at the national level, could you talk a little bit about Medicare's current approach to value-based care?
Sure. I mean, so I think at the end of the day, Medicare probably has two main flavors of value-based care. They have lots of CMMI programs, but the two main ones have been the ACO movements, the MSSP or ACO Reach, now ACO Lead. And the second has been Medicare Advantage, or the commercial privatization of Medicare. And really in those environments, Medicare Advantage providers frequently are looking to create value-based care payment economics for their network. So it's a little bit more of an indirect a way of getting at it. In both cases, the goal is to get primary care doctors to be accountable for both economic outcomes and clinical outcomes. And I think that's a laudable goal. I think it is the right way to align the needs of clinicians and patients and purchasers, whether that's the federal government or an employer. So I think the concept of value-based care, is a great one. I've spent a lot of my career in it. I think the challenge with it has largely been how these programs have been structured. And in some ways, the focus for success has been through things like coding and documentation or risk adjustment or curating a network using actuaries to kind of say, if we took these providers out and left these in, the performance of the ACO would be greater. Those are things that are not really getting at the heart of making people live healthier lives and reducing the total cost of care. So for me, what my focus has been, I think the challenge for value-based care, and the reason I think value-based care hasn't become the prevalent and predominant model, is that number one, there's a cost to participate in it. There's a complexity. There's an investment in technology and informatics and analytics that has to be overcome through the economics of the program. And then secondly, most doctors would say, I'm being focused on things that aren't really the most important things. That really, if I could have time to focus on helping my patient stay healthy and stay out of the hospital and stay out of the emergency department and take their medications and control their chronic diseases, those are the things that I want to focus on. But I'm being managed to care gaps and AWVs and risk and codes. And so so we're kind of heading down we kind of have the right idea. And I think the execution has largely just missed the mark a bit through the eyes. If you would ask most primary care physicians, they'd say that's their challenge with value-based care.
How do you anticipate AI programs will affect value-based care for primary care physicians and patients in coming weeks and months and years?
Yeah, I gotta say, I'm very bullish about the role that AI can play. If you think about it, right? If you're fortunate to have an outstanding primary care physician, you probably spend 2 to maybe 4 20 to 30-minute periods of time with them every year. And that's if you have a really good one who's accessible to you. And yet primary care is the net result of how you live your life every day. The foods you choose to eat, whether you choose to exercise, the habits you have as it relates to alcohol or smoking or vaping or other activities, whether or not you fill your medications, whether or not you monitor your own blood pressure or your blood sugar. All of these things are really important to your health. And for most of us, our primary care physicians, even the best ones, really their support for us stops the minute we walk out of their door. And we're kind of left to live our own lives between visits. And then periodically we come in for check-ins. Those may involve laboratory data, it may, vital signs, and then some time with the clinician. That's a construct of a world where the delivery mechanism is largely a human one. And the constraint, therefore, is how many minutes do the humans who are conducting primary care have available to them. And so the number of touches per patient, the number of patients are limited by that human constraint. AI offers the opportunity to totally unlock that. The way we've thought about it is that if AI starts with an understanding of your own data as a patient, so if the EHR data is available to AI, lab, pharmacy data, HIE data, claims data, potentially if that's available, consumer data, if that data is curated to give a digital view of you as an individual, and then that data and where you are in your healthcare journey is used as the starting point for AI to interact with you on behalf of your clinician, that's an amazing advance. It allows your clinician to oversee a care model that follows you outside of the exam room and is monitoring and sensing and supporting you. And then frankly, alerting the clinician when you're off track. So that maybe instead of waiting a random 6 months to come back in, maybe you are someone who needs to come back in 4 months because you're going off track. On the other hand, maybe you're someone who's doing great. You're fine. Like you're compliant with your meds, your weight's good, your blood pressures are great. And you wouldn't necessarily need to randomly come into my office just to sit down and for me to confirm that because I would already know that. So I think it starts to unleash this notion of healthcare being reactive and episodic and siloed to being continuous and connected and proactive. And I think in there, physicians get to spend their human time on the patients who need it the most, and patients get the value of the support of their clinician wherever they are, at home, at work, on vacation. and it's just part of your life. I think that's the promise of this technology if used wisely in primary care.
Hey there, Keith Reynolds here, and welcome to the P2 Management Minute. In just 60 seconds, we deliver proven, real-world tactics you can plug into your practice today, whether that means speeding up check-in, lifting staff morale, or nudging patient satisfaction north. No theory, no fluff, just the kind of guidance that fits between appointments and moves the needle before lunch. But the best ideas don't all come from our newsroom. They come from you. Got a clever workflow hack, an employee engagement win, or a lesson learned the hard way? I want to feature it. Shoot me an email at kreynolds@mjhlifesciences.com with your topic, a quick outline, or even a smartphone clip. We'll handle the rest and get your insights in front of your peers nationwide. Let's make every minute count together. Thanks for watching, and I'll see you in the next P2 Management Minute.
When you mentioned about the patient panel sizes actually going down because primary care physicians are becoming more responsible for more conditions. I'm oversimplifying that in my terminology, but I think the reality is that just from the outside looking in, it feels to me like primary care is in a sense becoming a fallback in the healthcare system to where we don't have enough endocrinologists to manage type 1 and type 2 diabetes. Some of that's going to go back to primary care. That's one example. And I think there's probably more. Where I'm going with this is I want to expand maybe on your thoughts here from a moment ago to get into some nuts and bolts with doctors and patients. As a physician, you have said successful technology must go beyond surface insights to orchestrate action between the care team and the receiver. I think you touched on that a moment ago, kind of big picture, but can you describe or give an example of how that works or what that looks like when the patient walks into the doctor's office and then, like you said, walks back out?
Yeah. So, wow, you packed a lot into that question for a non-doctor. That's really smart. I don't want to lose the first part of your question, which was this notion of the intersection or the interface between primary care and subspecialty care. It's a two-way street. In some cases, primary care has gotten so busy and the agenda of primary care is so busy per patient that the bar and threshold for referral out to a specialist has been lowered. Especially, and I think there's pretty good evidence that non-physicians, especially ones who have not been in practice very long, nurse practitioners specifically, tend to refer more readily than their physician counterparts. Largely that's because of maybe a lack of just experience or training. And so what has happened is that as primary care has gotten busy, they've also sent more care into the specialty world. Certainly within health systems, maybe you could argue that's even incentivized or encouraged, but that's the reality. What has now happened is access is a problem ubiquitously. It's not just an access in primary care. Access to specialists is also a problem. We were talking to a health system recently who said 30% of all of their cardiology appointments for the next 12 months are booked for patients who have hypertension as the problem. So if you think about it, right, hypertension is right in the wheelhouse of primary care. And I would say, 90%, maybe 95% of patients with hypertension should be well managed in a primary care practice. The fact that 30% of a health system's cardiology appointments are filled with hypertension visits is a challenge, right? That's not the best and greatest use of a cardiologist who trained an extra 3 or 4 years after his or her internal medicine training. So they would like to repatriate some of that care back to primary care, but primary care needs help. So what could that look like, right? Well, that could look like AI interacting with you as a patient to review whether or not you've taken your meds regularly before a visit. It could also gather your blood pressure readings. It could have taught you how to take your blood pressure at home correctly, and then it could have collected your readings. It could have aggregated that data, and it could have summarized all of that back to the physician to be right in front of him as he walks into the exam room to see you, right? So that instead of spending the first 5 minutes reviewing your blood pressure logs and all, it's already done for the clinician, right? And they could get in to the management of your blood pressure. What if that AI also took what was known about you and bumped it up against the world's evidence of management of hypertension and provided evidence-based guideline-directed nudges for you for that specific patient with a click button to the evidence if you wanted to see it, to basically say, for a patient like Richard on this drug with this condition and this renal function and these comorbidities, the evidence would suggest he should be on this drug in addition because his blood pressure is still above goal. And here's the evidence for that. That's the promise of AI, making an office visit more meaningful, preparing a patient and a clinician for that office visit to make the best use of the time, and then harnessing technology and being able to present that at the time where at the point of care where an action needs to be taken to say, hey, this is something you as a clinician should consider. So I think you start to see when that happens, you can imagine a world where where primary care doctors are managing heart failure. Maybe they're managing chronic kidney disease. Maybe they're managing type 2 diabetes at least, and the referrals to endocrinologists are far fewer. I think if all of us were using AI that way, we would still need specialists. But instead of them seeing 5 patients to justify the one that really needs their expertise, maybe they see 2 patients to see the one, and so that wait times become lower. They're still full, but they're not crowded with patients that would have been managed well in primary care. I don't know if that answers your question sufficiently, but that's kind of how I see the problem of specialty care versus primary care and how AI could be part of the solution here.
No, I think that is really an interesting angle. And again, one that I just haven't seen. Maybe I'm not coming across the right sources, but just haven't seen a lot in the professional or gray literature talking about that back and forth between
There isn't, Richard. So I think
primary care and specialty care.
Yeah,
I think that's fascinating though too.
So one of our partners is Wolters Kluwer. UpToDate has been a product that probably many of your listeners and readers are familiar with. Before open evidence existed, it was probably the source that most clinicians went to across the world to seek information on the management of patients. Well, Wolters Kluwer is a partner with us at Lumeris now, and they've taken their curated evidence and they've vectorized it or made it available to be leveraged by an AI tool through an API to kind of say, hey, we could assemble a question based on our understanding of a patient. We can assemble that digitally and automate asking Wolters Kluwer for evidence and for their best guidance based on what's knowable about this patient. And then that's happening in the background, and present that to a clinician at the point of care. Wolters Kluwer was over the moon when we talked to them about this idea, because what they've said is that the holy grail of clinical decision support is to marry the clinical information of a patient with the evidence. And historically, the physicians have been called upon to translate those two things. They have a repository of information and they're sitting in front of a patient, and it's been left to them to think, what are the facts about this patient that I need to push into this tool to get an answer to help me guide my treatment? Well, what if we could automate that? That's that cognitive burden that I think needs to be removed from primary care. And I think that we're on the cusp of being able to actually deliver that. That's not being delivered in the United States today. And so it's not that you haven't read about it. That's a net new thing. And certainly excited to bring that to primary care.
One of the things that I'm curious about here is that we know technology over time tends to become more reasonably priced, frankly. And right now things can be expensive, both from a software and hardware perspective. Can you talk a little bit about cost, both for the physicians who may be using some of the programs, and we know that smartphones are ubiquitous in our nation, of course, but there may be some other technology that's needed on the patient end. Where does that come from? Who pays for it?
Yeah, great questions. Well, let's start at the patient level. I mean, I'm wearing an Oura Ring. You may have an Apple Watch. I mean, people have devices. Those are not cheap. And so there is a little bit of have and have nots today from a technology standpoint. I do think that technology companies like ours, we need to build flexible architecture so that patients over time can bring their own devices to bear. Like, I don't think that any product can be built where it mandates for you to be a user of the product, you have to buy a specific technology. But the reality of it is there's very rich data in wearables or remote monitoring. The challenge generally has been that providers don't have the bandwidth or time to sift through the data and make good use of it. So it's kind of an interesting phenomenon. And if you're a driven patient, and I'm very interested in my sleep. So Aura provides a feedback loop to me every morning on how I slept that night. And there's embedded within the application tips and tricks for better sleep. I don't need a clinician. I can self-manage myself on that journey. And so it's a consumer tool. I choose whether it was important. I was willing to pay for it, and therefore I get value out of it. But for things like hypertension or diabetes or heart failure, where there's a monitoring capability that, frankly, to create value needs to be connected to a provider who is able to prescribe medications theoretically or frequently as part of the management, that loop is of interest to me. And I think there's two problems to solve. One is on the provider side. You've got to make that information very easy for me to digest and to consider in my treatment. And so AI is a great tool for analyzing large data sets, normalizing it, summarizing it, and presenting it to a clinician. So check the box there. On the device side, AI allows for kind of high or low tech versions of remote monitoring. High tech would be connected device, maybe Bluetooth enabled or cellular device that ports information directly into an EHR. And so there's a data integration activity, and that's expensive to do. The device may have an expense to it. And that's unclear who should fund that and how that should get paid for. There's a low-tech version of it, though, which is that you can buy an over-the-counter Omron blood pressure cuff for $39. And it very high quality. And AI can just literally ask you to read me your last 10 blood pressures. There's no deep integration. It's just literally AI communicating with you through text or voice to say, give me your blood pressures, Richard. Like, over the last week, can you just read them all to me? Thank you. And I store them in memory and at the right time summarize them and aggregate them for clinicians. So it's a complicated question. I think over time devices will get less expensive on average. I think product builders will build flexible architectures that'll kind of bring your own device, and we'll figure out how to take inputs in. The most important thing is, how do we connect those devices to a clinician? Because digital health tools, there's many of them out there. Most of them have failed to improve health outcomes because they're not closed loop back to a clinician who has the ability to prescribe or intensify medical therapy when your readings suggest that that's needed.
Any new technology, we know that there are early adopters. There's always skeptics. And primary care physicians are some of the busiest ones out there. Maybe they just haven't had time to really make a deep dive into AI yet. What advice would you give to a doctor who still is just kind of dipping their toe in the pool, so to speak?
Yeah, I think that's okay. I think healthcare has benefited from slow adoption at times. I mean, there's a safety reality. This is a new, powerful technology, and to the degree we turn it loose on either clinicians or patients, we should be thoughtful and careful. And it's okay that this is going to come in phases. I think early adopters are necessary to test and help validate these tools. And I think laggards, which sounds so negative, are sometimes just pragmatic and are just needing to see that evidence before they invest too much time. So I think that dynamic is okay. What I don't think is okay is to be a clinician in today's world and to just bury your hand in the sand around AI and pretend that this is just going to be another failed promised technology that's going to make my world better. I think that doctors, even the most skeptical ones, would benefit from reading about AI, reading in the medical literature what they can. It's okay to be skeptical, but I think being skeptical without information and without understanding and learning is challenging. It's not hard to learn about AI. You can cursorily kind of read medical journals and start to see now lots around AI. You could also go deep. You could go to Microsoft or Google or AWS and go online and have free access to AI primers and start to understand that. I think many physicians are using an AI tool, Open Evidence, and so they're starting to be familiar. Many are being exposed to ambient listening technology that gets them away from being on the keyboard in the exam room and starts to transcribe them. So I think clinicians are seeing AI show up in their world, hopefully in ways that are positive. I think it's a different thing when we start kind of placing AI in between a physician and a clinician, that we need to be thoughtful and careful and use good judgment and require proof points to be in the market before we just adopt that as kind of the new standard for primary care. So I think be interested, be curious, avail yourself of an opportunity to learn more, even if you draw a line between learning and implementation and practice. I don't think anyone should, as physicians, we're meant to be lifelong learners. This is a really exciting time in healthcare, and we should all, as physicians, shape how this technology is going to be deployed.
I'm Richard Payerchin, reporting for Medical Economics. My guest today has been Dr. David Carmouche. It's been a great conversation, and we could talk about AI and new technologies here for another couple hours. I hope we get a chance to catch up again sometime.
Yeah, I really enjoyed the conversation. I appreciate you giving me this forum to share some of my thinking. Thanks a lot.
Once again, that was Dr. David Carmouche, Executive Vice President and Chief Medical and Commercial Officer at Lumeris, speaking with Medical Economics Senior Editor Richard Payerchin. On behalf of the whole medical economics and physicians practice teams, I'd like to thank you for listening to the show and ask that you please subscribe so you don't miss the next episode. As always, be sure to check back on Monday and Thursday mornings for the latest conversations with experts sharing strategies, stories, and solutions for your practice. You can find us by searching Off the Chart wherever you get your podcasts. And if you'd like the best stories that medical economics and physicians practice publish delivered straight to your email 6 days of the week, subscribe to our newsletters at medicaleconomics.com and physicianspractice.com. Off the Chart, a business and medicine podcast, is executive produced by Chris Mazzolini and Keith Reynolds and produced by Austin Littrell. Medical economics and physicians practice are both members of the MJH Life Sciences family. Thank you.